Pancreatic cystic lesions presented by Dr. Abeer Muhammad Amal. Pancreatic cystic lesions pose a diagnostic challenge. MRI is an important diagnostic tool, and if there is any worsened lesion, it should be followed by EUS with EUS fine needle aspiration and cytology. EUS is a valuable diagnostic tool for pancreatic disease, but EUS findings by themselves are not accurate enough, so the results should be combined with clinical history, laboratory findings, and imaging studies. EUS is also performed as a preoperative tool. Mural nodules inside the cyst, wall thickening, solid component, and collateral vessels should raise the suspicion of malignancy. Fine needle aspiration is not advised for probable malignant lesions for which surgery is already scheduled. Pancreatic cystic lesions may be non-neoplastic or neoplastic. Non-neoplastic as non-epithelial cysts, true cysts, or others. Neoplastic lesions as serous cystadenoma, mucinous cystic neoplasm, and solid pseudopapillary tumors. Simple mucinous cyst. It is more common in older female, more in the body or the tail of the pancreas. It has a fibrotic wall with no ovarian type stroma. Pancreatic pseudocyst. It is not a true cyst because no epithelial lining may be communicated with the ductal system. It is a painful cystic lesion and is composed of localized collection of pancreatic secretions from damaged ducts into the interstitial tissue that is developed after pancreatitis, trauma, ductal calculi, or obstructive neoplasm. Serous cystadenoma. It is a rare benign neoplasm, more common in elderly female in the tail of the pancreas. It is asymptomatic lesion, and the CT typically demonstrates a demarcated cystic lobulated mass in the pancreas. It has an excellent prognosis. Watchful waiting is the main approach. Surgical treatment only for uncertain diagnosis or suspicious lesions or local infiltration into the adjacent organs. Glycogen cells is a pathognomonic findings in the cytologic evaluation after EUS fine needle aspiration. Fine needle aspiration carries the risk of bleeding due to the increased vascularity of the serous cystadenoma. Mucinous cystic neoplasm. It is a precursor lesion to pancreatic adenocarcinoma. Ectopic ovarian stroma is thought to be seeded, and the cysts are formed by hormones and growth factors released by the ovarian stroma, almost always in women in the distal pancreas, and metastasis usually restricted to the abdominal cavities, and metastasis to the ovary may simulate the primary ovarian tumor. Radiologically, it is a thick-walled single septated cyst in the body or the tail of the pancreas, has excellent prognosis. Invasive carcinoma include increase in the size, intracystic papillary nodules, or increase in the serum CA 99. Surgical resection is indicated for all mucinous cystic neoplasms. So, during the EUS fine needle aspiration, the endoscopist should select the regions of the wall with solid component if present and insist on poking the cystic wall to check for invasive component. The endoscopist should try to obtain material from the wall of the cyst. Solid pseudopapillary tumor. It is a low malignant potential tumors present in younger women in the body or the tail of the pancreas. Radiologically well demarcated heterogeneous lesion with cystic degeneration. Poor prognostic factors: increase in the size, male, necrosis, cellular atypia, or invasion. Surgical resection is curative in almost all cases. So any pancreatic cystic lesions do first MRI if no worsening features, so repeat the MRI in 1 or 2 years. If there is dilated main pancreatic duct or cyst more than 3 centimeters, so EUS with fine needle aspiration. If there is high grade dysplasia or concerning features, so surgery is highly recommended.